I'm going to turn it over to Donna, who's been waiting patiently as I go through my housekeeping agenda. This is Donna Montgomery. She is the VP of Advocacy on our board, as well as the VP of Nursing Informatics. One moment, please.
Thank you, Tammy. So I'm really glad we have such a large crowd today. I think the discussion that we're going to have today around patient engagement is something that all of us have to not only understand better, but also be very aware of how we utilize our technology tools to engage our patients in their care. We are learning as a nation that we as citizens need to take responsibility for our care and be a part of our care in order for us all to become more healthy. So this is a piece of how do we utilize technology to do that, and how important technology is in that road that we're all on as Americans. So with that, I'm going to ask each of our panelists to introduce themselves to you, tell us a little bit about your role that you're in, and then we'll go to some questions that the board has selected to talk about today on the panel. So Mike, I'm going to turn it over to you first and ask you to start us off.
Well, thank you. Thank you for having me. My name is Mike Gefeller. I'm the Director of Operations for HCA North Texas. I'm responsible for the operations of 13 hospitals in Oklahoma and Texas.
Thank you. Deb?
Hi, I'm Debbie Schumann. I'm the Chief Nursing Informatics Officer at Children's Health System of Texas. We have currently 3 hospitals. We just acquired OCH from Baylor, which is really expanding our pediatric reach into an area that we had not previously been. Myself and my team are actually very focused on how technology impacts the workflow of clinicians. So kind of our saying is that if it's technology and it touches a nurse or a physician or another clinician, then we need to be involved in the assessment and the planning for how that's going to be implemented. So that's it for me, I think.
Thanks, Debbie. So Nick?
Good afternoon. I'm Nick Reddy with Baylor Scott White. I do 2 or 3 things for the organization. I oversee all things IT strategy, our governance, and a lot of our strategic projects. Most things that have what I call anything from 6 months to 36 months out, analytics and digital and all those different things we're working on. So that's sort of my role at Baylor.
Brenda?
Hi, I'm Brenda Taylor. I am a Regional IT Director with Texas Health Resources. I currently have 4 hospitals that I oversee that are wholly owned with Texas Health. I have the smaller of the hospitals, and as we roll out some of the technology, sometimes we look at some of the smaller focal areas that's a more controlled environment, so we roll out all the technology. So I help oversee the strategies that Texas Health Resources rolls out.
Thank you. So I am going to just 1 second. I hope my slides did not get mixed up, Tammy. So with the evolution of the digital world, what would you see as the future for portals? And Nick, I think you and I had talked about this a little bit.
Thanks, Donna. The way we see it, information technology, as most of us know it, I think is pretty young in the grand scheme of things. I think internet, maybe the infancy of it is 25 years old. I think it started at CERN in Switzerland in late 80s, early 90s. So most of what we're working on is pretty infant at best. And if you see what happened to technology, I think in the last 10 years, it's really impressive. I think there's a lot of stats to articulate this point, but 2 or 3 statistics that are relevant from our perspective. Facebook. You know, there's more Facebook users today than the entire country of China, and Facebook is 9 years old. You just take a step back, and technology knows no boundaries. 40,000 searches on Google every second. 22% of those searches are healthcare. And what Google executives tell you in private is people trust Google and are willing to ask Google things that they're not willing to ask their own loved ones. 107% penetration of mobile technology in the United States. That means people have more than one phone, obviously. Number one traffic of internet. In 2008, during Beijing Olympics, NBC came out and said, for the first time in the history of this country, more people watched Olympics on their mobile phones. That was 7 years ago. So this is, in the history of our planet, nothing has been adopted widely and fastly than the technology, period. I think 100 years from now, when people write books about this generation, we will be compared to the Renaissance period or the innovation period in Camelot or the Industrial Revolution in 1800s. We're living in historical times. And as we grow technology, I think in the next few years, the way we see it in the digital world relative to healthcare, healthcare will virtualize. Most of healthcare today is physical business. You have to come to our parking lots. You have to fill out some silly forms. You have to sit in our, rooms, and then you have to go home. That's really our business, right? And I'm generalizing, obviously, but we believe that will change. Healthcare will virtualize a significant portion. We will be in a world where you will buy insurance online. We do believe in exchanges. We do believe more than 100 million people will go to exchanges and do that. I think today's workflow for insurance, I'm not sure how most of your companies are, but you get some email from HR at the end of October, and there's some sense of pretendness that you have choices, and you pick one of 3 buttons, pretending you do research, and most of us would agree there's no choice, and but it makes you feel good because you clicked one of 3 buttons there. That's going to change. It's going to consumerize itself. We believe that's going to change. It will have a much more robust way of consumerization. We believe you'll see physicians and clinicians remotely. The Northern California region of Kaiser just announced that they have more virtual visits than physical visits. So this is not even Star Wars. This is not a vision. It's happening today. Texas and Arkansas have some conservative rules, but the rest 48 states are there, and Texas will get there too. We're just different, obviously. We do believe, we will monitor health remotely. We definitely do believe that. Monitoring of health, which is done inside of our walls, will happen outside, and frankly, it will happen at a higher quality and a better precision. We believe so. We believe in a virtual business. So to answer the question, the future of the portals we think will be robust. I think it will be a triangulation. I don't think we'll call them portals anymore. I think that's frankly my sense is that's a government term because of MU check the box that we all had to do. That's why we call them portals. But I think it will be a digital landscape where you could do a lot of functions you're doing today in healthcare. Most of this has happened outside of healthcare for the last 10, 15 years. We're just slow to the party usually. But the way we think about it is the unstoppable force called American entrepreneurs, called consumerization, is going to hit the immovable object called healthcare, and we'll make a pretty good sized dent into this world. So we see the tectonic plates shifting in this space, and frankly, drink the Kool-Aid of all things IT here.
Thanks, Nick. Any comments by any of our panelists before we move on to another question?
I guess I would say I don't disagree with Nick at all, but I think the challenge is making the technology, whether you call it portal or something else, at the end of the day, care is still about people. And so how do you make those systems form a relationship with the patient? And that's something I don't think anybody's figured out very well yet. And so that's going to be the trick, I think, as you move forward, is how do you do that effectively?
Okay. So Nick, I'm going to ask you again on our second question today. So what would you say is the biggest technology advancement and that will impact how our patients engage, to Mike's comment, with health systems in the future?
I think let me start by using a buzzword, and then I'll try to explain what I mean by that. We believe in quantified self. If you ask people, what is healthcare business? What is it? End of the day, what are you doing in healthcare across the board? Most people will say it's an information business, right? Physicians have information and they're applying it. Clinicians have information, they're applying it. You go to a physician, you ask for advice, whatever have you. Based on how technology is going, and I'll use, I think most of the people in this room are very IT savvy. It's amazing how close technology is getting to a human body. I did my college applications on a typewriter, and my parents argued if they should buy me a computer. It was a big argument, right? Mice will go bad, you will do bad things, you'll get distracted. But it became socially, culturally, and economically acceptable to bring PCs into your house in the 90s. But that wasn't good enough, right? In 2000s, we bought phones because when we were mobile, we needed the computing horsepower. So we adopted phones like nothing before. And now we're adopting wearables. And most people, I say this jokingly, but we live in a country where we're willing to pay $500 for a watch and wait 4 months. And we all know there's no difference between that watch and that phone. But we still are willing to do it because it gives you quantification, right? And technology is getting on you and inside of you. I work with some of our cardiovascular surgeons that are putting stuff inside of you that's emitting information out. This is, once again, not future. This is now. We do this about 15 times a day. One surgeon does it 15 times a day. They put things inside and stuff comes out, information. So I think ability to quantify human beings, I think will be the biggest technology advancement that people will use in healthcare. Today we do with basic things like steps and calories and running. I think it will get more advanced into healthcare information. It will get into genetics. And frankly, a lot of us will be intelligent enough to know and monitor our own health. And we'll go to healthcare systems for advice or when we have a conflict or when we need an intervention. So quantified self, I think 5-10 years from now when genetics gets into the game, I think it will alter this. But that's kind of what I believe is once humans start understanding themselves at a molecular genetic level, I believe we'll see it. By the way, this will happen in 10 years. We'll see it in our generation, in our careers. This is not far away.
Comments from anyone on our panel?
I would just, lean back from the microphone. You commented that healthcare is about information. I agree, but I also think it's about caring. And I think figuring out how we can provide that caring and that attachment is also what will engage families. And I think some people say telehealth is too remote to really make that engagement, but I think that there are opportunities with telehealth. We have telehealth programs in 57 elementary schools in the city of Dallas, and kids can go and get their ear looked at if they have an earache and get that dealt with so that they can get their prescription by the time they get home. So I think that even reaching out through technology to patients is going to be a wave of the future.
I think data mining, too, I would say, is going to be a huge technology advancement in healthcare. Microscopes gave us the ability to see things that were previously too small. Data mining gives us the ability to see things that were previously too big. There's so much data out there that you can't possibly, pull it all together and see it all. And so the more data that you have, you make decisions, whether it's sepsis orders or whatever those things are that help make better decisions for the caregiver in real time. Those things save lives. And I think that the more data we have with the electronic health records, whether it's Cerner or Epic or Meditech or whatever it is, the discrete data that we're going to be able to pull out of that and do trending on and make decisions on will get better over time, and that's going to be a real differentiator.
Thank you.
Audience.
Yes. Do you have a question?
Yep. Sure. Sure. Good question. By the way, I think that's a problem every healthcare system in the country has, if I were to say, because you don't control where your patients go. So they go to wherever they want to go, and sometimes it's not within your boundaries. I think this is a fundamental issue about what I call the highways, the technology highways in healthcare are not built. I think we all know there's no secret sauce to this. Once again, I think this is, I'll use let's go to finance. You take money out of an ATM in China, your bank knows. They know you've deducted money in Beijing. How do they know that? Because they work with international clearinghouses, they have national clearinghouses, they built out the highways. Healthcare is just 20 years late to the party. They did that in the 80s and 90s, and we're doing that. I think we say interoperability, and most of us, the success of that is not great, I'm sure. Some of it is, some of it is not. But the highways just need to be built out. Once the highways are built out, I think you can get to the patient portals is a very, one of the several things you could solve. But right now we just don't have freeways between each other, right? We don't have roads to technology packages to go back and forth. And, we spend a lot of time arguing standards and a lot of time arguing rules and regulations and, RIOs. And we just don't have it. It's an industry gap. I'm not an attorney, nor am I a policymaker, nor do I predict the future. But most. Sorry, is there an attorney in the room? Or sorry, I just had to say that. I think I saw a camera recording. So, here's what I think health. At least when I look at it from a macro perspective, there's a macro and a micro vantage here. But the reality is, most organizations are trying. It's not working. How long, whoever's been in healthcare for a long time, how long have we been doing the interoperability thing? This is not the first time, right? How successful have it been? So immense amount of effort, probably more failure than success. It's not lack of effort, not lack of technology, not lack of anything. It's just not working. The business models are not there. So what large companies are doing is they're building their own infrastructure. They're creating ACOs, and they're trying to connect their ACOs, right? You're trying to connect your physicians and your JV partners, and essentially because you're going after what you control. The reality is most healthcare systems, even within their walls, are probably not connected really well if you really look underneath the hood. So a lot of them are saying, let's build narrow networks, let's drive our patient population to our networks, and let's connect ourselves so at least if the patients are within our walls, but if they go to a competitor or a peer's organization, if they're not part of our network, you almost kind of say sorry because the industry is not there. I think this will go down as the single largest gap in the industry. Something I don't know if this generation will solve realistically based on what I'm seeing. Just this, what I call a lot of activity, zero achievement in healthcare is how I frame it, to be blunt.
And to his point, there is a gap, and as healthcare professionals, our biggest goal right now is to educate our patients on the tools that we've got available for them, the portals that's out there. And I'm going to tell a little bit of a story. Several years ago, my father had a transplant. We lived in the Stephenville area, and he went to Houston, and that's where he had his transplant. And he would have to go between locations, and a lot of times he would have test here or in Steenville, then he'd go back to the Houston area. And there was a period of time he would always have to print off all these papers and stuff. And now, as they would make the trip, they would take their phone. When they would go to see their heart surgeon, he would say, well, okay, what have you had done? She'd pull out her phone and she'd say, here's all of my records. And he would go through her phone and go through it. So it's very important that we teach our patients what's available for them to be engaged in their health care. And until we get that gap filled, we've got to use the tools we've got available.
Question on that. In foreign countries, they're granted single-payer systems, but they're using chip and PIN cards, and they're putting all the patient data on there. It's portable, it's secure. All you have to do, no matter where you go, you put it in, and they upload all the stuff. It's simple. Why can't we do that?
You must be reading about Taiwan, obviously. I don't know why we don't do that. I think, by the way, there's a lot of people. I don't know, when patient portals first became a big thing with meaningful use, there's a whole contingency of leaders who would actually say that's the wrong thing to do. We need to get to, just a portable, so we give it to patients so they can travel. Why are we controlling their information? Why don't we give it to them so they can choose? That fell off. I don't know where that contingency is, but there was strong arguments for that case. I don't know.
And I think also meaningful use, the whole focus has been on transfer of information between clinicians, between hospitals. There hasn't been much focus at all on the piece of giving a patient all of their information regardless of where they had their care. So that's kind of, I think, where we need to go.
Great conversation. Thank you in the audience for your questions. So Mike, I'm going to focus us a little bit specifically into how do we get our patient engagement scores up? What are key areas that hospitals, and we'll focus on hospitals even though we know it's much bigger than hospitals, but let's focus on hospitals. Can you talk a little bit about that?
Yeah, so the simple.
Yeah, okay, sure.
Access to information. My question is, are people using patient portals? Do we have data on that? Who are using these? Because patient portal not only provides information, it can be used for education, it can be used for, there's several things you can do. It will be interesting to know who is using, what purpose they're using, and if they're not using, can we do something about it? I'm a little bit of an outsider. This is my first meeting. I teach at UT Arlington, and I do research in healthcare IT. One of the questions that is bugging me is about the usage of patient portals. Because are we just rolling it out to fulfill meaningful use criteria, or are people really using it?
So, okay, thank you for the question. I would like us to come back to that. I'm actually going to ask a question of Brenda because they're doing some very innovative things at her organization. She's going to share with us in a few minutes. So let's come back to that. Please keep that thought. So Mike, can you talk to us about the focus areas of how our hospitals can increase their patient engagement scores?
Sure. So HCA North Texas is engaged with the Studer Group. I'm sure a lot of you have heard of them or worked with them in the past. It's no surprise that, if you've got a large inpatient population, especially that comes from the ED, whether it's 40% or 50%, 60%, 70%, it's pretty well known that 5 to 10% difference in HCAHPS scores, you're going to have worse HCAHPS scores in those inpatient units from patients that are admitted from the ED versus direct admit or OR patients or cath lab or something like that. So the ED is an area I think that needs a lot of focus when you're improving scores, because if you just go after the inpatient units, you're going to have marginal returns on your inpatient satisfaction scores. The other thing is, certain departments drive those satisfaction scores. Usually the women's services line of business, newborn nursery, L&D. They're having babies. It's a pretty happy time for most people, assuming the outcome is positive, and most of the time it is. And so you tend to get inflated scores in those areas, and they're pretty happy. And so you really need to maximize those areas to make up for some of the areas that typically will be a little bit less, which tend to happen in med-surg units. There's a lot of pain involved in med-surg, and so pain management, is a key there. Across the board, communication with nurses is important. Cleanliness of the hospital, that sort of thing.
Okay, and so I'll give you the next question also. So how can technology, oops, I went the wrong way, sorry. Oops, going backwards. So what's the role technology can play in that, in the engagement of patients?
So I think technology is an enabler rather than a driver. My mom was a nurse for 40-some years. I say was, she's still alive. She doesn't stop becoming a nurse. When you're a nurse, you never stop being a nurse. And so you can give technology to the nurses, but it's about that relationship, as I talked about before. The last time I counted, HCA had about 165 hospitals. It varies from day to day, depending on whether we're buying or selling. But if you look at the HCAP scores, if you rank them, and we see those rankings, if you rank them from 1 to 165 in terms of how well they do, the difference is not technology. The difference between number 1 and number 165 is not technology. It's people and it's processes. They have the best, people doing the right things, and they're really tight processes, whether it's patient rounding, and nurse leader rounding, that sort of thing. And so I think the way technology can help that is things like rounding tools, right? Electronic rounding tools, things that supplement what a caregiver is doing, because it's gotta be something that enhances that relationship with the patient. Otherwise, if you're not doing that, I think you're going to fail.
Thank you. Any additional comments? Okay, so I think what we're talking about, Deb, to Deb Schumann, I'm going to ask you some methods that you're using to educate your patients on their disease processes, medications, and self-care. So that goes back to not just the technology, but can you talk about that a little bit?
Yes, we actually have quite a few ways that we educate patients about their disease processes and the care that they're receiving in the hospital. We recently implemented an interactive patient system, and we have the ability to actually identify teaching topics and points out of our electronic medical record that then go to the interactive patient system, and then the patient's to-do list has videos that they can watch about the specifics around their diagnosis, also about how they can function in the hospital. We have all of our education points are also have identified our third-party education material, so that if you're going to teach someone about diabetes, then you can automatically print out the education material from our third-party vendor that's related to diabetes and then hand that to the family. So we teach by having them watch videos. We teach by having them read material. We also teach by personal one-on-one education with the family, the child and the parent, and we are able to have all of that then documented in the electronic medical record. So there are quite a few ways. So we have a mix of technology as well as the hands-on interaction with the care provider.
Great, thanks. So, Deb, what about your organization? Are you all doing? Oh, I'm sorry. Somebody had a question.
We absolutely do, and thank you for bringing that up. We also have a patient portal. our electronic records Epic, and so we have MyChart, and that is available to families. We have all of our patient education material is also hosted through MyChart, so the families can look for that when they get home and really review everything that they were given in the hospital electronically, as well as search on other topics. So that's available to them as well. We also produce and publish their discharge instructions to their MyChart, so they're able to see when they get home, not only if they lose their paper copy or they throw it away on their way out the door or whatever, they can see when their next appointments are, they can see what their immediate discharge instructions were as well.
Okay. And can you talk a little bit, Mike mentioned some of the other activities that are needed for us doing a good job with our patients. Can you talk a little bit about what you all do from a rounding perspective?
Actually encourage the nurses to do hourly rounding with their patients, which they do in the course of delivering care. Many times it's not necessarily focused on a specific topic. We're not being as successful with that in terms of moving our NRC picker scores, which is our patient satisfaction scoring module, since pediatrics doesn't have HCAHPS at this point in time. And since it wasn't being successful, we decided to trial on one unit, having our administrative supervisors, who are here around the clock as well, do rounding on patients. And they started rounding on every patient every day, and they kept a log of who rounded on which patients. And they focused the questions around the things that NRC Picker looks at, which is, were you treated with respect by your nurse? Were your medications and was your care explained thoroughly by your nurse? Did you feel like the nurse spoke to you at a level that you could understand? And just doing that in 1 quarter, we moved that unit's NRC picker scores up into the 90th percentile. So in my mind, that really proves that if you are doing intentional rounding, having intentional conversations with patients, with families, then you are going to positively impact your scores. And I think Mike was exactly right. It doesn't matter how much technology you have, how little technology you have, as long as you're communicating with people in a way that they can understand and that's meaningful to them, then you're going to have a happier, better educated, and more cooperative patient and family.
I had a mini stroke a few years ago, and I was hospitalized. And during that time, the place where I was at did hourly rounding, and they would come in and they'd sign a little initials on the board, and then they'd walk out. I had a food tray there that was there about 4 hours, and the person came in, looked at it, and went and initialed the rounding and walked back out. I think Debbie has it right. It's got to be a meaningful interaction. So you can do hourly rounding and go in and initial something, but when you walk into the room and don't interact in a meaningful sort of way, it's kind of pointless, you know. And so I think the trick there is you have to have the right people doing the right type of rounding to make it meaningful for the patient.
The other piece that goes along with that rounding is that they also do real-time follow-up with the nursing staff. So if they get a response that says, you know, they came in and told me about this medicine, but I didn't really understand what she was talking about, they go back out to that nurse and say, hey, can we go in and figure out a better way to describe that medication and its interaction with that family so that they understand what you're talking about. And those one-on-one interventions also make a big difference, because that helps the nurse understand how you have to interact with that family in order to make a difference. I think you're exactly right. I was recently in the hospital as well, which it was a really good experience, but I swear to God, if somebody came in and asked me one more time what was my pain rating, I was just like, give me a freaking break. So, you know, you can overdo some things. So there has to be kind of the happy medium of how you interact with families, how you talk to families. And I end up saying families a lot because in pediatrics, you treat the family. It's not just that one individual patient.
So what a great example of how we've been able to move the bar with technology, because even though we always give feedback, and that's been, forever, even before we had technology, we would give feedback to the nurses based on things that patients told us. But to have that real time and be able to give them feedback during that shift while they're still caring for that patient, we're really optimizing the care of the patient and making sure that the right connections are being made. So great example. Thanks so much for that, Debbie. Yes.
Mike had mentioned electronic rounding portals or electronic rounding applications. Do your HCA facilities have many of those deployed? And for that matter, anybody on the panel, how effective are those if we have those in place?
So we're piloting a couple different solutions across our company right now. I won't get into the names of the vendors, but I think the results are TBD, but I would expect that they will be helpful. I think anything that you can do to take it away from paper, again, it's about the relationship, so it's not about the technology. But if they can interact with that patient and it makes it easier for them to document that electronically, I think that's for sure a differentiator. And to your point, if those results can go back to the charge nurse or to the nurse manager or nursing director or the CNO, and they can take a look at that in real time and say, I didn't get some good results here. Maybe I'll go around on the patient myself and try to do some guest recovery, right? And so I think that's the value in those tools that you don't get in a paper process.
We're also looking at a vendor to do electronic capture of rounding and the results because paper isn't the best process by any means.
I might also add just real quickly that we also, HCA has a chief patient experience officer now, which we didn't have before. We hired her from the Studer Group actually, about a little less than a year ago. And so I know there's other organizations that have done that, but we're making it a focus.
At Texas Health Resources, we do have an app that's got a rounding functions, and as the nurse rounds, they have a set list of questions to ask, and then they can customize a few extra questions. And then the report comes out each month as to how we did and et cetera. But we also, because the nurse gets busy, and if they're around every hour, how are they being reminded that they have to do this? And so we looked at several different pieces of technology, and we put in place the nurse call system, which integrates with our badge system. And as they step out the door, they hit a button, and then it sends them a communication when it's time for them to round again. Because you can get busy because you're taking care of multiple patients. So while we had the tool there for the rounding, sometimes we needed to have that notification put in place too. But we have been looking at the reports that comes out of My Rounds, and it has been a very useful tool, and we've changed several of the questions throughout, and it goes all the way to our quality measurements teams, and they look at that as well.
Okay, so Brenda, we're going to get back to the question from earlier, but first I wanted to ask you, what are some of the methods that your patients use to access Portal?
At Texas Health Alliance, we actually have a tablet that is on our wall that the patients use. It has the Epic Bedside app on it. It also has many, many other features on that tablet. Since we've opened the doors at Alliance, we've kind of expanded. We get a lot of feedback from the patients, but for the normal MyChart, they can get it on. If you've got a device, you can get it on there. I mean, the apps are out there. If you want it done, there's an app for it. And so if you've got you can get it on your phone or whatever. But from an inpatient side, the Epic Bedside gives you a lot of functions. You can see how the treatment team members and all of that. But we also, for the device we've got, they can adjust the temperatures in their rooms and a few other things. But right now, any technology, if you've got the device, you can get it on there.
So we might want to go back to make sure that if there's other questions about that from the audience or from the gentleman who asked the question earlier.
One thing that he had asked was, did we have statistics around access to portals and know how many of our patients are accessing portals? And we do report that. I don't know the number off the top of my head, but part of that is because we report it for meaningful use. So that is tracked, and we continue to focus on ensuring that our patients have, or our parents have access to MyChart before kids are discharged from the hospital.
And I think the other thing that I'm going to ask you, Brenda, to talk about, because I think you all have done some pretty innovative things, is how do your patients in your organization learn to use their portal?
When a patient is admitted at a couple of my facilities, we have what we put in place, what we call mission control. A lot of people ask what mission control is, and originally we looked at it as being our transporters on steroids. So they did a lot of things, and over the last several years, we've looked at how can this group of individuals who's real excited about transporting our patients back and forth to various places, how can they become engaged? And as they're transporting the patients, they started asking them the questions what to do. So what we've recently put in place is when a patient is admitted into the hospital, this mission control person has been moving them to their room. What they do is they orient the patient to the rooms there. They show them what the tablet is, how they use the tablet, how they can order their meals online with this tablet. We have refrigerators in the rooms because we have a diverse population around the Texas Health Alliance area. Not all of them will always have American food, so they have the ability to bring their own food up there as long as it's within their diet. You also have a lot of family members that bring in something while they're sitting with their their families, and they put it in their refrigerators. Mission Control monitors those temperatures. We have a temperature monitoring system on it, so they monitor those. They ensure that everything is out of the refrigerators, that they're cleaned with our EVS. They also introduce them to the patient portal. They show them how to get into Epic Bedside. The nurse will help them actually engage, and then Mission Control comes back out and answers any questions. We have safes in the room so that the patient can make sure that their valuables are taken care of instead of you putting your valuables in a bag and taking it someplace and locking it up. But we've looked at all kinds of ways that we can ensure the technology. They wanted to be able to adjust the temperatures in their rooms, so we partnered with our vendors to make that happen. That was a suggestion by a patient. And so as the patients are saying, this is what I would like to see, we're seeing what we can do, giving them the device on the tablet. It also can, if they want to see it on the big screen, they can do this on the big screen. So we have several different functionalities that's available for them. We also, when they go into Epic Bedside, it gives them a welcome video, talks about our organization. They can send a message to the president or any of our triad members. They can send messages to the care team members that we've got there. It shows on the bios, so we did we put all of the pictures from the employees' badges out there, so if I assign myself to the treatment team of the member, when the patient opens up the chart, Brenda Taylor is my nurse for the day, and here's what she's going to look like. Respiratory therapy, any care team member is out there for their bios. There's so much more in the Epic Bedside that's available. And as they go home, they transition, all of that information is transitioned, but we go through it through them. Mission Control also has we have a concierge button on these tablets, so if they need something, they call the concierge button. Instead of you always bothering the nurse or something else, the nurse can take care of your disease, and the Mission Control can get you a phone charger. We keep phone chargers available from all types. We check them in and check them out, so the patient can take care of getting better, and we try and make it available for them with anything that we can provide for them.
I've been listening to all your ideas and I've been thinking about adoption, and I think that's probably the closest I'm hearing to giving a patient the opportunity to give you feedback. My questions in general are, whether they were electronic or team-based motivational things, do you have programs in place to reward good rounding, great nurses and great experiences, and how are you acknowledging those good experiences, and how are you allowing your patients to give you the 4-star rating or provide these ideas that you've gotten, for example, in the temperature?
Well, as I keep referring to my magic tablets here, the tablets that we have in the room also, we customize a questionnaire on those. It's a basic few-point question, so they can just go into a SurveyMonkey. If it's on our OB department, it's customized for the OB care. If it's on our med-surg, we ask the med-surg questions, but we'll ask them a few basic, what would you like to see? What can we do to provide to you to increase your interaction and your care? And we've gotten a lot of good feedback. One suggestion was, some of the movies here aren't really that good. What's available? So we put Netflix on it, and we reached out to Netflix, and we have accounts, so we actually pay for that. We put, if they want to put their own account on there, they can, but we take all their suggestions very closely. We also have a committee that meets once a month to talk about these results, to talk about the surveys that we've got available, what else can we do for them, so.
Do almost 100% discharge, follow-up discharge calls to families and collect information that way as well around what we could do better. So that's also more real-time than they actually get the actual surveys that go out. And then our interactive patient system has the ability for the family member or the patient to identify who was especially helpful to you today, or, is there a nurse you'd like? They can nominate a nurse for a DAISY award via the interactive patient system. So there's a variety of ways as well.
Yes, I understand the benefit of having a committee to review findings and data and stuff that comes in. But what I'm interested in is who's on those committees. Because it seems like a lot of times, we've all ran into this, right? Where you got, these people who never did the work coming up with these ideas about how things need to be changed, and then the people who have to do the work, are retaliating and doing workarounds because they don't like the changes that were made. So when is there like a policy when you create committees like that to review these suggestions and things? Do you include patients or past patients on it? Do you include people in the community, or is it just hospital administration?
And we were building Texas Health Alliance. We actually brought in the community to find out what their needs were and what they wanted to see. So we had a lot of community members that gave us feedback on what they wanted to see within the hospital. And we have kept that going. When you ask what we've got on the committee, it was agreed upon that we would have no more than 2 senior level members on that committee, 1 manager and maybe 1 director. Everybody else would be at the elbow, who is actually seeing the work, hearing what is being said. So we've got a director that leads the committee, but the rest of them are the people that can really make the impact to our patients. We
actually have a patient family department, and so they have regular meetings with patients and families to talk about issues. On our service excellence group, we don't actually have a parent that participates in that, but we do have parents that participate on some of our other committees in terms of, for example, we have a parent that sits on our quality committee, so hears all of our quality issues and participates in how those discussions occur so that we can improve the care from a quality perspective.
Other questions from the audience? It looks like we have about 5 minutes before we would call our session today a wrap.
One other thing I thought about, we were talking about patient portals and how, like I just saw my doctor retired last month, and I got a new doctor. I just saw him yesterday, so I'm on a new patient portal. I'm also diabetic, and I have a doctor with the Diabetic America, and they have a portal. Doesn't it make sense then that at least for now, because that's what we have, our portals, regardless how effective they are, whatever, doesn't it make sense then that we should have the ability to link portals so that, I mean, if we don't have these big, I forgot what they were called, the health.
IEs.
Yeah, if we don't have those working all that well, I mean, shouldn't we at least, if I can link my portals, then my doctors are communicating with each other because I did that. I mean, wouldn't that be at least right now, one of the more effective ways of getting my information to all my doctors, as opposed to worrying about, somebody in Washington figuring out how to do that?
I think there's probably a Nobel Prize written on whoever solves this problem. I'll give you the Baylor Scott and White story to tell you how big of a problem this is, what you just mentioned for us. We have 5,000 physicians. I think we're second or third largest population health network in the country relative to physicians. 2,300 of them are our employees. So we pay them. They're just like all of us in this room. They do their goals and they work for us. The rest of them don't. And out of those, the ones that don't, there's literally 312, 270 EMRs, depends how you slice and dice it, right? So, and our patients, we encourage them to go to our population health network, right? So they traverse, they go to any one of those 5,000 docs, and they're all over the place, right? So a patient, and we're trying to do a little bit more sophisticated of a study. There's patients that have 22, 32 portals today. Obviously we have a mothership called Baylor Scott and White. If you work for us, you probably get one of 3 portals. But if you go to the rest of them, you're good luck, right? All the way from a fancy Excel spreadsheet to whatever else those 300 people have bought. The question that we're debating, frankly, is do we invest in solving this problem, or do we think about the situation differently? So, I mean, among all of us, it's not that difficult to spin off an IT team and start one of the largest interfacing efforts in the country and just try to connect them, and we all know what that will do for us. It will keep us busy for 5 years and 10 years. But do we do that? Is it the right way to do? I mean, I'll get into a very tactical, granular example. So if a patient, I don't know, wants to refill a med, well, if they hit that button on their portal, the master portal, well, we can allow you to do that because with APIs in our portal. But if one of these 300 folks, I mean, that technology is not that sophisticated. That physician probably bought that portal because it was cheap, right? That's how physicians bought EMRs traditionally, right? How much did it cost per month? So I think solving that problem, we wonder if it can even be successful. And believe it or not, the question, I'm not sure if other people are thinking about it. And we had breakfast with our head of population health network yesterday. This has become one of his top 3 problems. Both getting information and both engaging patients, right? Because if you don't engage patients, you won't win the population health game. You're going to lose it. And the best way to engage is through this strategy, right? So, and he's asking us, what's the best way to solve the problem? And we said, if you ask the IT folks, we will fail you in this. We can start a project, but it will lead to failure. But you will just find out that we failed 5 years from now. Do not solve it through interfacing and fancy technology. Could we fundamentally shift the game and go after their EMRs, right? Could we offer them an EMR that we consider ours, and put everybody on one platform? That's the right, because most people in healthcare today understand. This wasn't the case 5 years ago, but almost everybody today understands the difference between interfacing and integration. Even senior executives do, right? Interfacing doesn't work. Portal of portals doesn't work well. The technology is not there. So we struggle with this question, but once again, I've offered to write a nomination for a Nobel Prize for our team on whoever solves this. So, and if, but I think it's a tough problem we have today.
I think the other thing too is that this is not a case where if you build it, they will come. It's not like people are flocking to patient portals because they believe in the security of the internet when it comes to health matters. They don't. And so you have a lot less of an adoption rate for people using the internet for things like healthcare than you do for just Google and email and such like that. It's a much more private sort of thing. And so I think to Nick's point earlier, it may be a card in the future that's where the industry may go. And so nobody's going to spend a lot of money trying to build all these different portals, I don't think. And we'll see. I mean, I could be wrong, but I don't see that happening when the industry could change and it becomes something that they don't really risk anything by putting it on a card that they carry around to the extent that they put it out in the ether.
Rebecca's point, by the way, if you guys haven't seen this, I'm not sure where it was published. Taiwan did this, where before you go to, and it's really interesting, you look at this and you kind of go through this common sense as to why we don't do this. Before any visit to any physician in the country, you give a card, and you don't fill a form, you don't do anything, you just give them a card, and your records go there. That's how you check in, that's how you do everything, and you walk around with that card. By the way, we do that in this country for passports, for driver's licenses. So this is done. It's just for some reason not picking up in healthcare. So I wonder if this will happen. This is one of those duh moments. We don't have to be very intelligent. People are doing it. We're just not. I think. So, but I'm sure there's people in the country who will try to build a portal of portals, and I'm sure there'll be a large project trying to do that somewhere. I'm sure there is.
Make a lot of consultants a lot of money.
Yeah, exactly.
So, but I think it's a tough problem. I will tell you, it's a very tough, agitating problem.
I mean, we went for years with paper, then we've moved to the portals over the next few years, or the last few years, and now as we move to the health information exchange, I think in 2 years we'll be sitting around this room going, well, yeah, we did this. So I see that right now we've got the tools that works, not that great, but it works. And we're just moving now to the next level. It's going to take some time and feedback, but we'll get there.
So I'll add a comment about this that's coming from a little different angle. One of the things that you all will be seeing as a membership over the next month or so is an advocacy newsletter. And one of the things that we'll be communicating with you is many of us went to Washington, D.C. recently to attend the Himss Policy Summit. And we learned while we were there some of the questions and some of the problems that our legislators are trying to solve. And one of the things we heard, which I think will resonate with all of you, is that citizens are very concerned about people having access to their information. And so all of this stuff about portals and how do we transfer information between providers, et cetera, is very unsettling to Americans in general. And so, although that's been the path we've gone down from a technology perspective, there's a lot of questions that are being asked about, is this really the right direction, and how do we give power back to the citizens who need to own their health care and be responsible for their health care? So we're going to give you some information in our newsletter about what Himss is suggesting might be some ways to get where we need to be. I don't think Himss has all the answers either, but this is something that we're going to ask you all, those of you that are interested, to help us, because talking with our legislators about what our patients really want and what citizens in Texas really want are going to be important. So we'll be sharing some of that information with you all. I liked what Nick said at the beginning. We're in a very transformational time in healthcare, and as HIT professionals, we are being looked at within healthcare to help solve these problems. So thank you so much for coming today. I hope that you agree that this panel did a great job in talking about patient education. You could, yes, thank you. And I think that's it for the panel. Tammy, do you have a few things to close us with?
I just want to say thank you, Donna, for facilitating. What a great job you did doing that. So I died. There we go. I thank you all for coming on Friday. I can and learning from our expert panelists. I hope you took away some valuable information. We're all in this together to figure it out, and that's why we want to.